of the House Human Services Finance and Policy Committee to order. And the first order of business is to take roll call. So Ms. Hanson will call names, please.
Okay, good morning, members. Chair Schultz.
Present.
Vice Chair Bonner.
Present.
Representative Albright.
Present.
Representative Bolden.
Present.
Representative Burkle.
Present.
Representative Fisher.
Present.
Representative Frederick.
Present.
Representative Hanson. Representative Keel.
Present.
Representative Liebling.
Present.
Representative Moeller.
Present.
Representative Noor. Representative, oh, thank you. Representative Novotny.
Present.
Representative Pearson.
Present.
Representative Pinto.
Present. Present.
Representative Rasmussen.
Present.
Representative Robbins. I see you, thank you.
Present, sorry.
Thank you. Representative Sandell.
Present.
Wonderful. Representative Schumacher.
Schumacher present.
Thank you.
Okay, we have a quorum. So the second order of business is to approve the minutes. Representative Bolden, would you like to make a motion to approve the minutes for January 19th, 2021?
Yes, Madam Chair, so moved.
Okay, Representative Bolden moves the approval of the minutes for January 19th, 2021. Any discussion? Corrections? Okay, seeing none. All those in favor, unmute yourself, please. Say aye.
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 Any opposed? Okay, the motion prevails. The minutes for January 19th, 2021 are approved. Okay, members, we have a full committee hearing today. We're going to first hear information about PCAs, and then we're going to hear testifiers in an overview of our disability waiver programs. We're going to get into the weeds probably today, so I'm going to have questions maybe held until the end of each presenter. So just make a note of your question, and then after each presentation, I will ask members if they have questions. This is a really important issue. I worked on the disability waiver rate system rate formula for a year, and then I worked with Representative Lippard on the PCA increase that we did through, I think, the end of February. But Senator Jerry Ralph spent a lot of time working on this in the Senate. I just want to remark that, you know, as you know, Senator Ralph passed away recently due to COVID-19 complications, and he had a lot of compassion and interest in increasing the wages and the benefits for PCAs. They're not paid very well, and they don't have great benefits, and they do a lot of important hard work. So we have a shortage of them across the state, and it's important that we work on this. So it would be really, really wonderful if we could make a tribute to Senator Ralph and pass some really important legislation on PCA rate forms, increase the rate and make sure that that increase in rate goes to wages and benefits. So we're going to probably be hearing a bill later this session on PCAs, but this will give you background information and get you ready to hear that legislation. So the first I'm going to introduce on the agenda is, whoops, that's the wrong packet. Give me 1 second, sorry members. I have too many things open on my desktop. Here we go. We're going to hear from Natasha Merz of DHS, and then we're going to hear guest presentations from Rick Varco of SEIU and Dena Belisle of the president of the Minnesota First Provider Alliance, and then we'll have Q&A after those presentations. So Natasha Merz, welcome to our committee, and you can begin your presentation when you're ready.
Thank you, Madam Chair and members of the committee. My name is Natasha Merz, and I'm the Director of the Disability Services Division at the Department of Human Services today. And I just want to check in and make sure can the committee hear me okay?
We
Madam
can,
Chair?
Natasha.
Okay, excellent. So I'm here today to provide this committee with a high-level overview of home and community-based waivers, the personal care assistance program, and provide some context for you all about the differences and similarities of those programs, as well as talking through a little bit some exciting reforms and work we've been doing in the department that we want to share with this committee and with stakeholders. Next slide, please. And nope, just give us a second for the technology to catch up. You could move forward, Christy. All right, so I think we're maybe having some challenges getting the PowerPoint up, but I'll just kind of talk through our agenda for today, or what I'm hoping to present to you all, which is an overview of long-term care services and supports and how home and community-based services, including waivers in the PCA program, fit into that broader category. We're going to talk a little bit about kind of the basics and foundations of the disability waiver rate setting system and how that's different from the rate setting mechanisms for the personal care assistance program. Again, I'll share an exciting project on the waivers that we are excited to share with you, as well as workforce challenges facing the direct workforce or the direct support workforce. So great, looks like we're back in business on the visuals. So when we in the department and sort of in common parlance use long-term care services and supports as a term, we're referring to a really broad set of benefits, an array of services available to help support people with disabilities and older adults. And LTSS includes care provided in nursing homes, intermediate care facilities, and institutional settings. So we talk about LTSS, we're talking about home and community-based services plus other services that are provided in institutional settings. Home and community-based services are a subset of LTSS, as I talked about, and they are cost-effective alternatives to institutional care. And the goal and purpose behind those programs really is to help people live, work, and participate in community life, as well as meeting their health and safety needs. So we have state plan benefits for home and community-based services, which includes the PCA program. Waivers, and we're going to talk about waivers, and then other federal funds, and then there are some state-based grant programs as well that provide support, but we'll focus on waivers and PCA for purposes of today. So it is definitely consistent with federal and state policy that we really do want people to be receiving services in their communities rather than in institutional settings like nursing homes and assisted living, or nursing homes and ICFs or hospitals. And so this graph just shows that roughly 88% of people with disabilities and elders receive services in the community rather than in an institutional setting. So I want to talk a little bit about medical assistance state plan home and community-based services. Minnesota has a comprehensive benefits set. And when we talk about state plan, we're talking about the federal authority that authorizes this particular set of services. And the federal authority for state plan services has different rules and regulations than the waivers that I'm going to talk about. So it's just important to know that the rules between programs are different, and sometimes that's because of the federal authority in which the service is authorized. So when we talk about state plan services, we're referring also to the personal care assistance program, home care nursing, or nursing services that are delivered in people's homes for people that need that, as well as skilled nurse and home health aid visits. All of these three state plan services have set rates. And we'll get into more detail about what that looks like in a minute. So home and community-based waivers were, and we also talk about the federal authority, and that's a 1915C for those of you that are looking for that site. But they were enacted by the Reagan administration in 1981. Minnesota's first home and community-based waiver was the developmental disabilities waiver, first authorized in 1984. And when we use the term waiver, what we're saying is that prior to 1981, Medicaid could only be used to pay for services provided in institutional settings. And so the waivers that we talk about were sort of saying we are waiving that particular old Medicaid rule to allow people to receive services in the community. So that's the origin of the term waiver when we talk about those services. One important thing about waivers is to know that people have to meet a certain level of care. They have to, without those services, they would otherwise be in an institutional setting, and that's different from eligibility for PCA, and so I'll talk through that in a minute. So this next chart just really gives you an overview of the average monthly people served between the disability waivers, elderly waiver and alternative care, and then state plan home care services, as well as annual cost of spending for these programs. Okay, I am going to now jump in and provide a high-level overview of the personal care assistance program as well as rate setting. And again, these are state plan services. So unlike waivers, state plan PCA services do not use a framework or formula to set rates. They are sort of flat rates that are set and adjusted by the legislature and don't include inflationary updates. So currently the rate for a 15-minute unit of service for the PCA program is $4.45 or $17.80 an hour. 72.5% of the rate must also go to must be attributed or go to direct support professional wages and benefits. As I mentioned earlier, the PCA rates are adjusted periodically through the legislative process without automatic increases to account for inflation, and any increase in rates requires legislative approval. Our data certainly shows that personal care assistants are the lowest paid workers in the home and community-based services workforce. Roughly $12 an hour in 2018 data compared to $12.29 to $13.50 for other HCBS services. So the slide you have up in front of you right now really just shows you the different comparisons between the rates. So we see when we talk about a flat methodology, we're saying there's no automatic adjustments and increases have to be authorized by the legislature. And when we get into DWRS, that stands for Disability Waiver Rate System, and has some additional components and complexity to calculating the rate and automatic adjustments that I'll talk through. PCA rates have not kept pace with other comparable home and community-based services. Services that provide similar levels of direct care activities as PCAs are paid at a minimum 40% higher in the disability waivers than in the state plan benefit currently. Next slide, please, Christy. We also wanted to point out that the Personal Care Assistance Program is one of the most diverse long-term care services and supports programs in Minnesota in terms of who receives it. So in state fiscal year, as you can see, 54% of all PCA participants were identify as members of the BIPOC community, Black, Indigenous, and people of color. Okay, I'm going to pivot next to the direct support workforce shortage, which is, of course, a critical issue in both the PCA program as well as home and community-based waivers. So just thinking about the direct support workforce, obviously the quality of services really does depend on supporting, on having a dedicated, well-trained and well-supported workforce. It definitely, having a well-trained direct support person in your life leads to better outcomes and more consistent care. And certainly we have seen that the whole long-term care industry sector really struggling with workforce shortages, and Minnesota currently has about 135,000 direct support professionals, and we estimate that an additional 68,000 will be needed in coming years to meet anticipated demands with the population of Minnesota. So I want to talk a little bit about wages for direct support workers. 45% of direct support professionals live in households earning less than 200% of the federal poverty level. And many variables affect wages and benefits that are paid to our direct support professionals. But some examples, just to give you a sense, is, how much the service pays, how much it costs to administer any benefits that employer is offering, and other related employer costs. So for services that have a physical building component, those components are costly as well. It's important to note here that the state, that the Department of Human Services, as the state Medicaid agency, sets rates for Medicaid services that employers of the direct support professionals in turn pay and wages along with using the rate for other allowable expenses. And the wages that are paid to people may be set by different state laws or federal labor laws. Next slide, please. So the rate that the Medicaid agency, the rate that is paid out or available to be billed for the service is a driving factor behind how wages are set. I think it's important to know within HCBS services, there are notable variation in payment rates, which has led to variation in wages for workers as well. So we can see that wages for personal care assistants tend to be lower than counterpart services, including the unit-based services that exist in the waiver system. Next slide. So just wanted to share that we in the department do understand that we play a critical role in addressing the workforce shortage, as well as other areas of the state and other state agencies in the private sector. So we have definitely been working on this issue in partnership with the Olmsted subcabinet and taking, really looking at kind of a multi-pronged approach to understanding and addressing what is going on. So we've developed new policies in the disability waiver rate system, new investments in service rates, and new data collection so that we can really understand what the true cost of providing services is and make sure that our rate structure is sufficient to cover those costs and pay fair wages. So I just wanted to note we have added a link to the Olmsted workforce shortage work plan if you want to see in more detail some of the different efforts and strategies that we are engaged with other partners across the state to address this issue. Next slide, please. So despite these efforts, we have seen a very dramatic increase in vacancies in the personal care assistance program. You can see this chart over time and the fairly dramatic increase in vacancy rates that really started climbing between 2012 and 2013 and is pretty significant, is very significant today. So I think I will pause there, Madam Chair, and see if you'd like the committee to ask questions or if you'd like me to keep going, whatever works best.
I think, are there any technical questions? I mean, this was a lot of information, and Ms. Merz, you speak faster than I usually speak, so kudos for that to get through this, but I think we have one from Representative Bonner. Go ahead.
Really quickly, I noticed that we had seen a pretty sharp increase in the vacancies in and around 2010, 2012, and it seems fairly stark that it at that time. And I'm just curious if you have any additional insights into what may have led to sort of this large discrepancy. Certainly we know that pay is always an issue, but I'm curious if there are other factors at work as well.
Director Merz.
Thank you, Madam Chair, Representative, for that question. So, I think like anything, it is a very multifaceted, issue that's really driving those numbers. I will maybe offer a small insight, which is when we started seeing the recovery from the Great Recession that, sort of started in 2008. Once we saw the economy starting to recover and more jobs outside of the long-term care service sector become available, people that might otherwise have been direct support professionals, decided that they could or figured out that they could sometimes make higher wages in other sectors of the economy. And so I think that may be one driving factor to see sort of that really stark increase in vacancy rates that you were referring to.
Representative Bonner.
Thank you, Madam Chair. Thank you, Ms. Merz. I appreciate the follow-up.
Yeah. Okay. Representative Chair Liebling, go ahead.
Okay, well, thank you. This really is a technical question. You've used the term state plan a number of times, and I just, maybe I missed it, but could you just define that for members, state plan as opposed to what? I think it's really an important concept for members who are just starting to work in this area.
Director Merz.
Madam Chair, Representative Liebling, yeah, that's an excellent question. So when we're talking about programs that are funded by Medicaid. The states have agreements with CMS, the Centers for Medicare and Medicaid Services, that sort of represent how the state plans to use the federal dollars that are matched when we deliver services to people in Minnesota. So, in general, if we spend, $1 on services for people, we get a federal match of about $1. And it varies from program to program. But the important thing, I think, to give context to Representative Liebling's question is, state plan is under a certain federal authority called the State Plan Authority. Home and community-based waivers are under a distinct authority that is that 1915C. So the rules for those services and the requirements for those services are different because they are authorized under different federal legal authorities. And I think the key difference between a state plan benefit, like a personal care assistance program, versus a home and community-based waiver program is that state plan services are what we call entitlement services. So if a person meets the criteria for meeting the service and meets financial eligibility, the state needs to make those services available to people. We have to ensure that we have a statewide capacity to meet that need, and those services are authorized according to that individual's eligibility. Whereas on the waiver side, under 1915C, states do have more discretion to think about how they spend, and they can limit benefits to control costs in certain ways. And we really, in Minnesota, hope not to do that, but it is a key difference between an entitlement service under state plan and then a home and community-based waiver. Another key difference is in the state plan authority, people don't need to meet a level of care determination the way they do on a home and community-based waiver. So under home and community-based waivers, people have to sort of prove that if they weren't receiving waivered services, they would have to be in an institution to meet their needs. So sort of a higher level of complexity in terms of needs. Whereas in a state plan service, that level of care determination isn't required. And so there are eligibility criteria that are built into statute and in our agreement with the federal government on state plan. But generally, it's sort of easier for people to qualify for state plan services than they might for waivers, depending on their condition or kind of the diagnoses or why they're coming into the system.
Thank you, Director Merz.
Great. Thank you.
Liebeling?
That's perfect. Thank you.
It's a great question. Representative Fisher.
Thank you, Chair Schultz, and this is for Ms. Merz. Going back to slide number 14, which is the direct support workforce, I had a couple of questions. This is, in terms of the numbers, it was mentioned that we currently have about 135,000 direct support personnel out there, with 68,000 more needed in the coming years. And when I hear 135,000 people, I'm wondering, is that all those people, are they all full-time? Are they part-time? What is the composition of that workforce? Are there, does that include overtime that's in through there? So I'm just trying to get a better understanding of what the workforce issues and needs when we're talking about actual bodies out there.
Director Merz.
Thank you, Madam Chair and Representative Fisher, for the question. So I can kind of provide some high-level information, and then certainly if you're looking for more detailed information about the composition of the workforce, we have several reports and we could follow up in more detail on that as well. But I think to answer your question, no, not all of the 135,000 direct support professionals are full-time workers. Some of them are and some of them aren't. We find, especially in the personal care assistance program, but in other programs as well, that there are people that do the job because they have a relationship to a particular person in their community. It could be a family member, it could be their friend from church, or any other type of relationship where they wouldn't otherwise be doing the work, except they want to be able to support someone that they care about in their community or in their family. And so those folks are maybe not working full-time and are perhaps serving just one particular person in their life. And then, to provide the contrast, we also have people that are direct support professionals that are really dedicated to this work and, feel called to serve in a full-time capacity and have, multiple people that they may be working with. I would certainly say to answer the overtime calculations or what's being paid out in overtime is not accounted for in just the number of direct support professionals. So I don't think that this is a good measure of getting a sense of how often people work overtime. So I think I'll pause there and see if that was addressed the question sufficiently.
Thank you, Director Merz. Representative Fisher?
Thank you, Madam Chair. Thank you, Ms. Merz. I think that gets to a lot of what I was trying to get an understanding is when we're talking about the workforce needs out there and what the composition is. But I did hear the offer of the additional information, and I would look forward to having that sent forward, because I think as I drill down to it, that might start getting more into the minutia of things, and I don't think that's, we can do. I can get that off the report. So I want to say thank you for the opportunity to get some of that information. Thank you.
Thanks, Representative Fisher. And Director Merz, I'm going to stop you there and take testimony from Rick Varco from SEIU, and then one other testifier, and then we'll come back and talk about the disability waiver programs. So let's see. Mr. Varco, are you ready with your presentation? If so, please proceed and introduce yourself to the committee.
Sure. Chair Schultz, members of the committee, my name is Rick Varco. I represent SEIU Healthcare Minnesota. Our union represents 40,000 Minnesota healthcare workers in hospitals, clinics, nursing homes, and self-directed home care, which is what we'll talk about today. Let me just get my screen sharing going here. All right, today I want to give you a little background history of our home care organizing, explain your role in ratifying and funding our contracts, discuss how our contracts help the public, and try to outline the various programs we represent. The most important thing about our union is our history, and that our members were left out of much of early labor law. Things like the Wagner Act and the Fair Labor Standards Act excluded home care workers because most of this work was done principally by women and people of color. Because of racist and gendered assumptions about what counted as real work, home care workers were treated as second class, and our members organized their union to reverse this historic wrong. Moving on, I think you saw all the stats that DHS has outlined. We think the reason for those low wages and the workforce shortage is the lack of labor law protections. It's certainly not a lack of demand. Home care is one of the fastest growing job classes, and the seniors and the elderly desperately want workers who can help them live at home instead of in a nursing home. The state wants the same thing too, because it's a far less expensive option. So that's why in 2013, 3 self-directed programs, PCA Choice, CDCS, and CSG, were added to the Minnesota Public Employee Labor Relations Act. That allowed workers to form a union, and we currently represent about 20,000 workers. I should point out that this is an open shop union. All workers are covered by the contract. We represent them, but membership and dues are purely voluntary.
Mr. Varco, can you explain the acronyms too for the CDCS and CSG?
Yeah, I'm going to get to that later in the presentation. It's Consumer Directed Community Supports and Consumer Support Grants. So I want to talk a little bit about our the ratification of our contracts. Like all public sector contracts, SEIU contracts must be ratified by the legislature. Our members will vote to ratify. Then it gets sent to the Legislative Coordinating Commission Subcommittee on Employee Relations, and then they forward it to the legislature, and you can act on it. A unique thing about our contract is it requires a separate appropriation to go along to fund the contract. This is different from other state contracts where normally the legislature passes a budget, the department then sits down with their union and decides how to spend some of that money and then sends that contract to the legislature for ratification. We always have 2 parts of legislation, one to ratify our contract and then the other to fund it. It's always been included in the governor's budget bill and passed as part of the omnibus HHS bill. I'll note we do move standalone bills that have always had bipartisan co-authors, something we're very proud of. We've had 3 two-year contracts ratified so far. You might have noticed some social media stories of our members celebrating their most recent tentative agreement. Governor Walz and Lieutenant Governor Flanagan really took this issue to heart. They each spent time working alongside some of our members on our Walk-A-Day program, and when they had the opportunity to do something, they went big. But we can talk about those details maybe later. What's in our contracts? The most important provision in our contract is probably the minimum wage. The current minimum wage is $13.25. It's if the tentative agreement goes into effect, it will be $15.25 next year. It's important to note that this is a minimum wage. People can be paid more than the minimum wage. Another critical benefit is paid time off. This has proven especially important during the COVID pandemic. The workers we represent were able to take some paid time off if they needed to quarantine without facing the choice of completely going without pay, which has been important. We have holiday pay, time and a half for 5 paid holidays, which we are hoping to add 2 floating holidays in the tentative agreement we have. You'll also be interested in the contract creates a training fund that allows members to get additional training like CPR, and there's a St. Paul College class on home care essentials. Our goal is to make home care jobs the first rung on a career ladder that leads to higher skill, higher paid jobs. There's also a grievance process. This is especially important to combat wage theft, which the Department of Labor will say is this is one of the industries where that's a problem. It provides a formal process for workers to retrieve their wages that is more efficient than going to court. So far, we've been able to recover over $250,000 in back pay. I should just note, workers are public sector employees only for the purposes of collective bargaining. They are not eligible for the state pension or the state healthcare plan. And also different from other public sector contracts you might have seen, the client has the right to hire, direct, and terminate an employee at any time. So Chair Schultz wanted some more detail on the kinds of programs that we represent that are covered by the contract. I've prepared this sort of grid that outlines the programs and some of the differences. I'll walk through these differences in a second. But you'll see here that we represent the 3 self-directed programs, PCA Choice, CDCS, and CSG. I've included the traditional PCA program, which we don't represent workers in because it has a connected funding. These programs also differ based on whether or not people get assigned hours of service or a budget and their funding source. So let me walk through some of those differences. The most important one is the concept of self-direction. Traditional PCA is not a self-directed program, and we don't represent workers there. The way that works is the client qualifies for a set of hours. They then find a worker. It's often somebody they know, a friend, a relative, a neighbor, and they go to the agency and say, I'm sorry, they go to the, I got ahead of myself. In traditional PCA, they go to the agency and the agency just has a worker that they've recruited and trained. That worker then comes and works for the client, and the worker remains a private sector employee not covered by the contract. In PCA Choice, the client qualifies for hours and then brings a worker, somebody they have recruited, often a friend, family member, neighbor, and all the client, all the agency does is provide payroll services for the worker. That worker is covered by the SEIU contract and eligible to join our union. The other 2 programs that are budget models, CDCS and CSG, are both entirely self-directed. Instead of hours, the client qualifies for a cash budget, and then they can use that cash to hire home care workers, but they can also use it to cover some other needs. The difference between the two is CDCS is a Medicaid funded program that has joint federal state funding, whereas CSG is entirely state funded. Again, the client approaches the provider agency to serve as what's in these two programs called as a FMS or fiscal management service. They provide the payroll, but again, the worker is an employee of the client and covered by the terms of our contract. The last couple of important points that are important for you as legislators to remember is that by federal law, the PCA choice program and the traditional PCA program must have the same rate. So when the contract is ratified and DHS increases the rate for the PCA choice program to pay for it, they automatically in the same legislation raise the rate exactly the same amount for the traditional PCA program. What this means is for employees in the traditional PCA program not covered by the contract, any increase in pay or benefits depends on the provider or agency taking action. A rate increase does not necessarily equal a wage increase. The wage is not necessarily the rate. It is for the folks covered by the contract because the rate is paying for the contract benefits. This also means that when you're looking at your budget spreadsheet and you see a line item that says X amount of $1 million appropriated for the SEIU contract, some of that money is actually going to fund the traditional PCA rate increase that isn't covered by the terms of the contract. So with that, I'll just say we think this has been a great partnership between the state and the workers to make sure that the money you appropriate is getting into the hands of workers. It's been a bipartisan success story, and we look forward to talking to you more about it this year.
Thank you, Mr. Varco. I think this was really important points that you highlighted here for members. Are there any technical questions for Mr. Varco before we move on to the next presenter? Chair Liebling, do you have a question?
Yeah, thanks, Madam Chair. I was having a little trouble finding the raise hand button there. Thank you, Mr. Varco. That is a great presentation. Really, really helpful. Probably the best I've seen this just laid out. It's so important for us to understand. Just to kind of put a fine point on it, you touched on it, but one of the struggles we've had, as you know, is that, when we want to raise wages for PCAs and people say, oh, we need a $15 an hour minimum wage for PCAs. The legislature has a real struggle figuring out how to do that. Could you just explain that a little bit more? I mean, you did touch on it, that, how to get this all to filter through, but I think it's so important for people to understand how complex this is and that we can't really do it from that direction and make it happen. Thank you.
Mr. Varco?
Chair Schultz, Representative Liebling, members of the committee. Thank you. Yes, we think one of the real value addeds to the public and the legislature to the contract is, at least for the 3 programs that we represent, you have a pretty good idea of what you're paying for, and that additional money will go to provide certain improvements for workers. There are a few mechanisms that provide some oversight for the money that goes to the traditional PCA program. But in essence, it is up to providers and agencies, because those are private sector employees, to determine how that money is spent. And again, you make a good point that the rate increase is not necessarily a wage increase.
Thank you, Mr. Varco. I see another question from Representative Sandell. Go ahead.
Thank you, Madam Chair and Mr. Varco. You mentioned that the PCA was an employee of the client. That means that a spouse, a son, or a mom or dad could be the PCA and be paid as a PCA. Is that correct?
Mr. Varco?
In the PCA choice program, yes, the client is the employer. There are some restrictions on hiring family members, but those restrictions, a couple of those restrictions were lifted during the COVID emergency. I've got a colleague, Phil Cryan, on here who may want to jump in and explain a little bit more about that. But I think it's spouses were not eligible to serve as a PCA.
Mr. Cryan, do you want to jump in with anything, add to that?
Thank you, Madam Chair and members of the committee. I would just defer to DHS, who I know are on here, to make sure that we get the correct technical answer, but what Rick just said is correct.
Okay, thank you, members. Representative Sandell, I'm going to leave it there and move to the next presenter. So our next presenter is Ms. Belisle. She's the president of Minnesota First Provider Alliance. So if you want to share your slide deck and introduce yourself to the committee, welcome.
Thank you for having me. I'm trying to figure out how to get everything on here. Can everybody hear me okay? I hope. I'm not very techie, so this is new for me. Can you hear me?
We can hear you.
Okay, thank you, Madam Chair. Madam Chair and members of the committee, my name is Dena Belisle, and I am the president of the Minnesota First Provider Alliance, a statewide membership association for personal care assistant providers, or PCAs. I run a small PCA agency from Lakeland, Minnesota, providing both traditional and choice services. But most importantly, I am the mother to my son, Anthony, who is 39 years old and severely disabled. He receives 12 and a half hours of PCA services per day. From its inception in 2016, the Provider Alliance has advocated for increased wages for PCAs and to establish best practices and higher integrity standards in our industry. The Provider Alliance believes strongly that the PCA program is one of the most cost-effective service delivery models for individuals with disability and older Minnesotans, and likely saves the states tens of millions of dollars a year by keeping individuals in their home and out of higher cost care settings. Out of the approximately 44,000 people who access the PCA program, 54% are individuals who are Black, Indigenous, or people of color. The majority of the PCA workers are BIPOC and women. As PCA providers, we were excited to hear about the components that were included in the tentative collective bargaining agreement, or CBA, that was reached over this past weekend. If ratified, it would mean we could pay our dedicated, hardworking PCAs a livable wage. That would be huge for decreasing worker turnover, increasing access, and improving quality of care. The agreement is one step. The next step is the funding that is needed for the agreement. PCA agencies have been stretched to the max by the underfunding of past contracts. If the state fails to fully fund this contract, I am not sure how many of us will be able to continue to provide PCA services. The Provider Alliance cautions policymakers that passing significant wages and benefit increases without an adequate increase to the state reimbursement rate could lead to the collapse of the PCA program. Furthermore, the Provider Alliance believes that a data-driven, cost-based rate framework should be implemented alongside the CBA to appropriately determine the state's medical assistant reimbursement rate for PCA services. This rate framework has been in development with the Provider Alliance and other advocates, legislators, DHS staff, and representative of the SEIU since 2018. Over the last two biennia, the minimum wage for PCA providing services in the PCA Choice program has increased by $2.25 an hour, while the reimbursement rate has been increased by only 68 cents per hour, or 17 cents per 15-minute unit. Not only do these rate increases fail to cover the increases in wages, they make absolutely no accommodations for increasing in payroll and unemployment taxes or worker compensation costs that are associated with the wage increase. Nor do they account for the paid time off also included in the contract, or holidays that are to be paid at time and a half. When paying time and a half for holidays, a choice provider loses money for every hour worked. They pay at a minimum $19.88 per hour, but are reimbursed only at the $17.80. If the state had kept the proportion of wages and benefits established in its first collective bargaining agreement in 2015 and funded subsequent contracts to the level, today's PCA agencies would be reimbursed $6.17 per 15 minutes or $24.60 per hour instead of the current $4.45 per unit or $17.80 per hour. That is a shortfall of $6.88 per hour. Prior to the COVID-19 pandemic, which drove up the cost for employees onboarding, personal protective equipment, and many agencies were teetering on the brink of closing. If the state does not give PCA agencies the rate we need to pay our employee the wages and benefits they deserve in the CBA, I do not know what's going to happen. The PCA program as it exists is not sustainable. The PCA rate framework proposal would determine PCA rates using data-driven method similar to the one already in place for the other like services that use the Disability Waiver Rate System, or DWRS. PCA reimbursement rates would be determined by collecting data on work experience requirements, pay rates, administration costs. We all know and must acknowledge that being a PCA is a necessary, valued career. Therefore, we need to create regularly increasing viable living wages and benefits for this type of work. Thank you for letting me speak today.
Thank you, Ms. Belisle. And so I appreciate your comments and really highlighting the importance of setting that rate appropriately so providers can pay those higher wages. Any technical questions for Ms. Belisle? No? Well, thank you. Thank you for your presentation. Hopefully you can hang out. There could be questions after our next discussion of the Disability Waiver Program. So I'm going to bring back Director Merz to finish her presentation on the Disability Waiver Programs.
Thank you, Madam Chair and members of the committee. I'm going to provide a high-level overview for you all of the Disability Waiver Rate System. And this is the rate setting mechanism that funds about roughly 80% of services that are delivered under the disability waivers. So those would be the Developmental Disability Waiver, CADI, CAC, and Brain Injury Waiver. Next slide, please, Christy. So the way that that rates are set for waivered services under that 1915C authority I had talked about earlier uses what we call a rate framework. And that rate framework includes component costs for what we understand about what it costs to provide services. And the combination of those different component values added together with specific sort of formulas produces a rate for that individual person using that individualized service. So we have the ability in DWRS to set rates based on spending data and analysis. But as I talked about before, since we aren't the employers of the direct support professionals, we don't set the wage. The wage floor may be set by things like the collective bargaining agreement or other state and federal labor laws. So for example, DHS may assume that the wage that a direct support professional is earning is $13, but ultimately the provider may choose to set their wages at $15 or at $12, depending on their business management practices, and then of course within any other legal constraints that support that particular service. So other components of the rate framework include things like the cost of providing benefits, the cost of supervision for maybe a more seasoned professional to be supervising the work of the direct support professional, program support, and other administrative costs. In the current DWRS system, the wage component, or the assumptions that we make about the wages that are being paid for a service, are set by an analysis of BLS codes, and that stands for Bureau of Labor Statistics, and these are occupation definitions and data collection that identify the statewide wage for all people working in that particular job. So the data collection is ongoing and values are updated annually in the spring. And so we make wage assumptions that are updated biannually within the waiver rate system. Next slide, please. Oh. So this is, I know the prints may be small, members, for you to be able to actually read the components, but we wanted to just provide a visual example of a rate framework that may help, kind of flesh out what this process or what the rate setting methodology looks like. So you'll see that each framework has specific inputs that allow for an overall rate calculation for the individuals being served. Talked a little bit already about what those inputs are, but it's the type of staffing, how many people are needed, is it a one-to-one service, or where it's one staff to one individual receiving services, or is it one staff to 3 people receiving services, for example. So what we've shown you here is a unit-based service called Integrating Housing Support Without Training. So that's just, again, an example of one framework and we've added some inputs into that so you can see how the rate is calculated. One thing I want to highlight, if you can read it in the first box, step 1, you'll see a percentage increase attributed to what we call a competitive workforce factor. This was a new cost component implemented in 2020 that basically for direct support professionals working in waivered programs, it was designed to be able to provide some additional funding or additional percentages in the rate to acknowledge the fact that employers need to pay competitive wages to be able to keep people in their workforce and in their organization. And the competitive workforce factor was one strategy to address that dynamic, but it exists only in the disability waiver rate system as compared to the PCA program, which doesn't have an equivalent. And again, important to just draw attention of the committee to the fact that the PCA rate setting methodology is a flat rate set by the legislature. There isn't this level of detailed and information that informs how that rate is calculated currently.
I'm going to pause there. I see a question from Representative Robbins.
Thank you, Madam Chair. Yes, thank you. I met with a provider in my district during the last session, and one of the things you referenced was that this is somehow tied to the Bureau of Labor Statistics codes. And this provider in my district was very frustrated by this. He said it's a 5-year look back that sets the base. And I don't know that that's accurate, but I wondered if you could address the BLS code and how that affects the rate and how far back they are actually looking. Thank you.
Director Merz.
Madam Chair and members of the committee, thank you for that question. So on the 5-year look back, I would like to invite one of my subject matter experts to just kind of come up and explain that look back period to make sure I'm providing fully accurate information to the committee. But I also would draw attention to, and I'll talk about this in my next slide, cost reporting that we're implementing that will give us data that we think is more accurate than the BLS codes related to calculating wages. So we do recognize that, certainly when we had to implement DWRS, that was the best available data that we had to make assumptions about the wage component of the rate framework. But we've been working since then to, seek authorization from this body and have to implement cost reporting. That will be a better set of data from which we'll make assumptions about the wages and rates in the future. So regarding the look back period for the BLS codes and your question, getting from my people that it actually looks back 30 months, and that changed during the 2019 legislative session.
Representative Robbins.
Thank you. Just one follow-up, Madam Chair.
Go ahead.
Thank you. So when you say that look back period now 30 months, thank you for clarifying. But you're switching to a new system that's based on cost. Could you articulate a little bit more about what that new system will be and when that will be governing how this is working?
Thank you, Representative Robbins. And Director Merz, I think it's in your next slide. So if you want to continue with the presentation.
Thank you, Madam Chair. Yes, it is addressed in my next slide. So I'll ask to get that presentation back up, or maybe my view is such as that I can't see it. Oh, here we go. Okay, so the disability waiver rate system continues to be evaluated and updated based on new data and analysis. So traditionally, we've also done sort of one-time surveys or used that national data that we referenced. But beginning in 2021, all providers of DWRS services will begin reporting their service costs as sort of required reporting, so cost reporting that we're seeking to implement. And then, as we collect that data and analyze it, it will allow for Minnesota-specific data to inform future decisions about wage assumptions and other component values within the frameworks. But it's also important to note that the BLF codes are identified in statute and will remain to be the basis for all rate setting related to wages. So we're hoping to have some additional and better data, but we do have a statutory obligation to utilize data from the BLF code, from the Bureau of Labor Statistics codes. And I think in the interest of time, I will keep moving, and then certainly I'll be available after for additional questions from the members and also follow-ups that we could do offline as well. So I wanted to just spend a little bit of time talking about a significant reform project that we're working on in the department and with stakeholders called Waiver Reimagine. So what we've really heard from people, if we talk about home and community-based waivers, the first one being authorized under the Reagan administration, these services and all the different waivers that we have kind of developed and grown up independently of each other, which means that the rules and the program requirements, the policies and the procedures have looked really differently, even though they sort of perform similar functions for people. And so what Waiver Reimagine is fundamentally trying to do is to simplify the system, make it less complicated for people and more transparent so that people really understand what services and supports are available to them, and they can build a life that has supports and services, that they build a life that matters to them, and then think about how supports and services can come in and augment that or help them have the life that they want to have. So we've certainly heard from stakeholders over the years that it's really hard and really complicated to learn and understand these programs. Therefore, how can they make informed choices about what they want and what they don't want? So we've just completed the initial stage of the Waiver Reimagine, which we're really excited about. We launched it or started implementing in the middle of January, which is we have a common service menu across all of our 4 existing waivers. So people don't have to spend time strategically thinking about whether they should go on to CADI or onto the DD waiver, because the services and supports are available are the same across. And within those services, there is a good bit of flexibility to allow for person-centered planning process and to meet individualized needs for people. So what we're hoping to keep moving forward with is after the common service menu is consolidating to 2 waivers that would be accessed based on whether a person lives in a provider-controlled setting or lives in their own home or family home. And then also implementation of a statewide budget methodology so people understand how much money they have to work with to, again, build that plan along with other services and supports they might have access to. And within that also includes the ability for expansion of self-directed options, which really relates, as this committee has heard before, with the person being able to be the employer of their workers, their direct support professionals, and take on some of those employer responsibilities with support for compliance with payroll and things like that through other services. So this is just a small introduction to Waiver Reimagine, and we'd be really happy to come back to the committee and talk in more detail, or again, provide any information that members may have offline. And this is a slide that shows some resources if you want to do some self-study. And I really appreciate the opportunity to introduce you all to this project and look forward to ongoing discussion about it.
I believe
And
Representative.
finally, thank you.
Thank you. Really appreciate this information, Director Merz. And I believe Representative Albright has had a question. Go ahead, Representative Albright. I don't believe we hear you, Representative Albright, and I don't think you're muted.
The first couple of questions I have, Madam Chair, for Director Merz, and this goes back to a slide that she initially started talking about the Olmsted subcommittee, subdirect group. And it's under Executive Order 1913. It rescinds 15-03. And I'm just curious, just from a process perspective, what reporting to the legislature is required of EO 1913? To whom, if there is any reporting enumerated or elaborated on it, to whom is that required? And it specifies in there that you are directed to use whatever resources necessary to carry out your objectives. And I'm curious what those objectives what financial obligations the Olmsted Group or the subcommittee has placed on itself. And if you could just elaborate in terms of what accountability measures under that EO are directed back towards the legislature.
Director Merz.
Madam Chair and Representative Albright, thank you for that question. I think it's helpful to provide a little bit of context. Minnesota's Olmsted Plan is a sort of cross-state agency group that is responsible for implementing a statewide plan to ensure that the mandates of the United States Supreme Court decision, Olmsted v. LC, are made real and made practicable in Minnesota. So the Olmsted Plan has a lot of different goals and metrics associated with those goals. And in general, the department reports to the Olmsted Implementation Office and Subcabinet in terms of providing those reports, the sort of mandated data reports that track progress or show where we may not be making the progress that we need to make. So I'm not aware of any specific reporting requirements to this body. I could be wrong about that. I just am not sure off the top of my head. But certainly, Representative Albright and Madam Chair, if you all are interested in additional information about what we do report to the Olmsted Subcabinet, where we are in terms of goals, that information is readily available and we'd be happy to provide it. Did that answer the question sufficiently, or are there maybe follow-ups, Madam Chair?
Thank you.
Chair and
Go
Ms.
ahead.
Merz, I think, with in an effort to keep us on track, I would like to know in terms of what allocation of financial resources you have utilized and what you are currently encumbering the state with. And this is not to be derogatory, but it just certainly seems like we would, as the funding mechanism for the Olmsted project, whether it be through a subcabinet or otherwise, we should be made aware of what type of budgetary obligations are being placed upon the general fund or other agencies and be made aware of that. And I think it would be beneficial if that you directed that to all the members of this committee in some type of written form in the very near future. I'm sure you're coming back to talk about the waiver reimagined. So maybe we could take a little deeper dive on that when you come back to the committee. When you talk about DWRS rate setting, and I noticed you talked about the competitive workforce factor, does that competitive workforce factor attach itself to other cost components as kind of the tail on the kite in terms of acting almost as if it were an inflationary feature for cost components such as administrative or support expenses that wrap up into the overall rate for someone who would be participating in the DWRS program?
Director Merz.
Madam Chair and Representative Albright, thank you for the question. Specific to kind of the mathematical calculations for the competitive workforce factor, I'd like to ask my colleague Elise Bailey to address that question specifically so she can answer the question the most accurately possible.
Go ahead, Ms. Bailey.
Hi, Representative and Chair. This is Elise Bailey. I'm the Fiscal Policy Director of the department. The competitive workforce factor was determined through data analyzing the difference between the wages in this industry versus the wages of workers that are competing for jobs in with the same level of experience and training. And so that actual factor is attached to the wage in the formula, and then all the other factors are added to it. So it's somewhat of similar to an inflationary adjustment, but it's database based on the differences in wages between different industries.
And I thank you, Ms. Bailey. And I believe I recall, Representative Albright, that because of federal regulations, we couldn't call these inflationary adjustments. This is why it's called a competitive wage adjustment.
And Madam Chair and Ms. Bailey, that competitive workforce factor, how often is that reassessed?
Ms. Bailey?
Chair, Representative, in law, it doesn't change over time. However, the department is required to analyze the data on a regular basis and report to the legislature on what the new research has shown. But nothing in law requires us to change the factor, I believe.
Madam Chair, Ms. Bailey, you articulate that you review it on a regular basis and then you report that to the legislature. At what point are you autonomously changing it, or would you require or be obligated to request legislative enactment of that new rate?
Ms. Bailey or Director Merz?
Chair, Representative, we are required to analyze it in law every 2 years, and we'll have a report coming out next month on what that research is. There's nothing in law then that allows us to change it, so it would be up to the legislature to change the formula in statute according to the new research.
Okay, thank you, Representative Albright. We need to move on, but those
Madam Chair,
great questions, Representative Albright.
Madam Chair, if I could just ask the gentleman from SEIU if he just knows the value of the collective bargaining agreement, what the value of that proposed agreement is that was just recently concluded.
Okay, quickly, Mr. Varco, please, if you have that information.
My quick answer is I would punt that to DHS.
Director Merz, do you have that information available, or can you get back to us with that?
We can certainly get back to you with that information, Madam Chair.
Thank you, Madam Chair.
Thank you, Representative Albright, for those questions. Representative Moeller, and then we need to move on to the last two presenters.
Thank you, Madam Chair, and I'll be brief, and I think this is probably something that may be addressed later with the waiver reimagined if we have more information about that later. I hear from constituents who are frustrated often when they're trying to receive services that they have to essentially describe the worst day in their life rather than different accomplishments and things. And so I'm just wondering if waiver reimagined addresses that at all.
Director Merz?
Yes, thank you, Madam Chair and Representative. That is an excellent question, and certainly we have also heard that from stakeholders. I don't think Waiver Reimagined will directly address that issue, but it is helpful, I think, to understand the context in which people are raising those concerns. Eligibility for either waivered programs or state plan benefits or other long-term care services and supports. It is true that under federal law, states are required to complete an assessment that indicates that there's a need for support or service in that particular area. So in order to sort of maximize the amount of benefits or sort of identify what services and supports are really needed for someone, recognizing that all of us have good days and bad days in terms of how our physical health or what we're able to do. And the same is true for people with disabilities, that the assessment has to capture sort of the bad days, quote unquote, or the days in which the level of need is deepest, in order to make sure that the support plan or the services that are being authorized as part of that support plan really do meet those needs. We make, to the federal government, one of the rules and regulations in both of these programs is that the state has to ensure that people's health and safety needs are met as a condition of the receipt of that service. So the people doing assessments at our lead agencies need to feel confident that the plan that is put in place and the services that are being authorized will maintain a base level of health and safety for the person. Waivers provide additional supports and services that don't relate to health and safety, such as for community integration, having meaningful activities during the day, things like that. So it's not just about health and safety, but there is that baseline requirement that people have to, that the state has to meet on behalf of the person when they're assessing their needs. And it is difficult and challenging for people to have to be talking with someone about that. And I think we recognize and acknowledge that. And we have really worked through our Min Choices application, as well as training for lead agencies doing the assessments, to do whatever they can to perhaps to promote a conversational process where a person is really also talking about their strengths, what they're good at, what they want to do, what the goals are in their life. But there does need to be a conversation from a health and safety perspective about what do you need to stay safe? And often that involves describing the most, the days that are where the need is the greatest, in order to, again, maximize in order to make sure that person has access to all the supports and services that they need.
Thank you, Director Merz. Representative Moeller? Okay, moving on to our next presentation, we have Ms. Maren Hulden of Legal Aid, and this is in association with the Minnesota Disability Law Center. Welcome to our committee. Please introduce yourself and then you may proceed.
Thank you so much, Chair Schultz and members, for having me today. My name is Maren Hulden, and I'm an attorney with Legal Aid, which includes the Minnesota Disability Law Center. The Disability Law Center is Minnesota's protection and advocacy agency, which means that we are federally designated to provide free legal services to children and adults with disabilities across the state. So we serve many clients who use both of the kinds of home and community-based waiver service programs that you've heard about today from Ms. Merz. And we are very supportive of the efforts to implement a rate framework for the PCA program and to address the workforce shortage and low wages. But I'm here to talk to you about some of the issues that our clients see and experience in using the waiver programs that Ms. Merz has just talked about. And thank you to Ms. Merz for that very helpful overview. I'm going to share my screen because I do have a very brief PowerPoint presentation. So I'm going to go through quickly 4 main issues, and one you've already heard about, thanks to Representative Albright. First and foremost, our clients are really, many are driven to live in community like everybody else. We have come a long way from the middle of the last century when the typical life for people who have disabilities was an institution. Now we know that people who have disabilities can and want to live lives like everyone else with their family and friends, finding meaningful ways to spend time and contribute to community. And waivers can provide the services and supports a person might need to do this. As Ms. Merz noted, Olmstead is a 1999 Supreme Court decision that affirms the Americans with Disabilities Act mandate that people who have disabilities be offered services and supports in integrated settings and communities, not just institutions. And as you've heard, waivers are the way that Medicaid supports that. This can look like, instead of living in an institution, living in an apartment with a roommate, living with your family, or living on your own with the supports that you need. Many people use waiver services to give them the support they need to work a job. Sometimes they need support to figure out how to write a resume or build the skills they need to get a job, and also to participate in community activities. And one of the, from our legal perspective, it's the push for this integration really does come both from the Americans with Disabilities Act and from Medicaid. Medicaid, now we have these waivers available and kind of a push to get as many people into integrated settings and out of institutions as possible. And we're grateful for that from the Centers for Medicaid. And And this is something that we see our clients wanting all the time and that we continue to push for on their behalf in various policy ways. So I also appreciate the question, Representative Albright, about how we hold ourselves accountable to moving forward with our own state's Olmstead plan. The next issue that our clients often see is about informed choice and having meaningful options to choose from. So informed choice is a concept that is built into Medicaid, and it's also a key part of fulfilling Olmstead. And we think of informed choice as really having two main components. One is that people get information that is accessible to them about what their options are. So say a person is on a waiver. Do you want to live in a group home? Do you want to live with your family? Do you want to live with a roommate? Do you want to live on your own? And really giving folks a chance to understand what those options are. And a lot of times, that might mean more than like one sheet of paper. I think a lot of times about what it looks like to pick a college for a graduating high school student. Oftentimes just looking on websites isn't enough. You go on tours, you talk to people, you read information. And so depending on the decision that a person might, or a choice a person might have about how to use their waivered services, we think it's important for people to have enough information to truly make those choices. The second piece is that those options actually exist and that they are truly available, because even if they are options in theory, they're not truly an option if they don't exist. And so these two areas are places where our clients do happen to see a lot of challenges right now, and we're looking forward to working with all of you and appreciate the efforts the department makes on this front. The first is that informed choice is done really differently across the system. I think if you ask 10 different people to describe it, you might get 7 to 8 different answers. And so that's one area where, depending on the county, depending on the caseworker, some of our clients are really getting strong, robust, informed choice when they're making decisions, and some of our clients don't. Another challenge that we see is that unfortunately, not all the options may actually be available. And so someone may go through this assessment process, which Representative Muller just asked about, and go through a very long process to figure out, okay, yes, I do want to live with a roommate and I do want to work in the food service industry. And then those options may not actually exist. And I think one of the challenges that we've had is certainly this, delivering systems is very complicated. And so when there are options available that kind of bundle all of the services together, this system has kind of gravitated towards those options because they're a little bit easier to deliver, but those are fundamentally kind of by definition, not individualized, and sometimes can also mean that people aren't seeing real options to work in the community or live in places that they choose. The third kind of challenge that we see, and this, I think your question, Representative Muller, gets to this, is about accessibility and navigating the process. The getting on a waiver is really complicated. So because it's a Medicaid service, someone actually, has to be eligible for Medicaid, which can be challenging, a difficult process to navigate, especially for, if you're a person with a disability, and that presents challenges to navigating those processes. There's also a timing issue. Sometimes people end up going through the Min Choices assessment before they're eligible for Medicaid, and that can make things really complicated as far as, making sure that they don't lose the window that their Min Choices assessment generated. The Min Choices assessment itself presents a lot of challenges to folks. I think exactly your question, Representative Muller, it's not only is it kind of demoralizing for folks to have to present their worst day, but we see that not everybody knows that that's what you should do if you really want to get a fair assessment of what your waivered service needs might be. And then we see a lot of barriers for folks who aren't as well versed with how the system works. We see barriers for folks where there are cultural differences, where there, as far as, cultures around talking about disability, and then certainly language differences can really make it difficult for folks to, and assessors to understand, especially if there aren't words in other languages to describe the kinds of things that assessors may be asking about. Another challenge is that it's really hard to do that kind of assessment that's so complicated consistently and equitably across the state. Though I think just even from the short discussion between Ms. Merz and Representative Mueller, you can appreciate that the min choices process is really complicated. And so it does take really skilled assessors to do that well. And that's, we are facing a workforce shortage generally. And I think that having skilled assessors in every county across the state has been a challenge for us. And so sometimes, and then cultures, you know, within different lead agencies too, can lead to just different, we often see person A in one county and person B in a different county might have fairly similar presentation of disability, but end up with different sets of services. Or maybe even more frustrating for a person is if they move from one county to another, sometimes they can get really different assessments of what their budget would be like and what kinds of services they would get. The last issue that we see, and this is one that we've been worried about for a long time and are starting to work to collect data on, is that, as you might have noticed from Ms. Merz's presentation about the demographics of the PCA program, is that BIPOC Minnesotans and Black Minnesotans in particular who have disabilities are very overrepresented relative to our statewide population in users of the PCA program. And one of the things that makes us wonder about is, you know, the PCA program is fantastic. The PCAs are amazing, but it is a narrower set of services. There are lots of things that waivered services can provide that you can't get through a PCA. PCAs aren't nurses. PCAs don't do certain things like, ILA, independent living services, which kind of helps people manage their appointments, or the day-to-day tasks, or even things like homemaking to help, make sure that people can take care of their own homes. Those aren't available under the PCA program. And so, we worry that there are folks, BIPOC folks and Black Minnesotans across the state who are not accessing waivers who really would benefit from that program. And I think that might be happening for a couple of reasons. One is that just our program pathways don't always lead to that more expansive set of services. Someone might get on the PCA program and the case manager might say, okay, we'll see how this goes. And, if we need more down the road, then we can look at waivers, but then that second part never happens. So they're just simply not offered it when other folks might know about it from friends or might be asking for that specifically. The other thing is that, as you also heard, the people who provide PCA services are often family, friends, are disproportionately women and women of color. And so we also have heard from our clients that the waiver service offerings could be more culturally reflective of the communities that we're seeking to serve, and that the options available under waivers might it might be a harder pathway to get your cousin to provide your direct support professional services under a waiver than under PCA. And so this is a conversation that we are having with our stakeholders and our clients, and we hope to continue to have this conversation with you. We don't have all the answers, certainly, but we certainly want to make sure that all people in Minnesota have access to the disability support services that they need.
Thank you, Ms. Hulden, for that perspective. Really appreciate that. And we will have more testifiers when we hear individual bills. Apologize for the last two presenters. We're going to quickly get through their presentations. So next up is the president or the CEO of ARRM, Sue Schettle, and we have John Nelson, executive director of RSI. So welcome to the committee.
Thank you. Good morning, Madam Chair and committee members. My name is Sue Schettle. I'm the CEO of ARRM. We are a trade association representing about 150 home and community-based service providers who support about 30,000 people with disabilities in Minnesota. ARRM was asked to testify today to talk about how our members operate within the DWRS system. I am co-presenting today with John Nelson, who's a very active member of ARRM, and he will really speak to the services that providers offer. But I just want to talk a little bit about ARRM, just real briefly, knowing what time it is. I'm cutting back my testimony. ARRM members are licensed as home and community-based service providers and are regulated under statute, specifically 245D. 245D licensed providers must work within the constraints of DWRS, and our members receive approximately 95% of their revenue through Medicaid, or from Medicaid, with rates set within DWRS. with approximately 75% of that revenue dedicated to staff wages. What you may find interesting is that Minnesota is the only state in the nation that sets our waiver rates in state statute. So when we want to make adjustments or changes to those rates, we have to come before you and present, our changes. So it's an interesting bit of information. As I wrap up my testimony, I just want to talk about a couple of challenges that we have within our sector, and you heard a little bit about it from Natasha and Merz. But we have a huge workforce challenge. We currently have about a 20% vacancy rate with about 18,000 open spots. You can imagine how challenging that is for providers before COVID. Once COVID hit, residential providers were had to be available during the day to support people who would have otherwise been going to work or going to a day program because those programs were shut down. So our providers were definitely stepped up to that challenge, but it still is a challenge. And most of the direct support professionals earn about $13 an hour, which is not a living wage. I will end my testimony right now, and with your approval, Madam Chair, would ask John Nelson to talk about DWRS from the provider perspective.
Thank you, Ms. Schettle. Mr. Nelson, please proceed.
Thank you, Madam Chair and committee members. I appreciate being able to share a provider's perspective today. I too will try to abbreviate and not repeat anything that's already been discussed. As Sue stated, my name is John Nelson. I am the executive director of RSI and have been in that position for the past 33 years. RSI is a nonprofit organization. We provide HCBS services for people with disabilities and people with mental illness in 7 counties in East Central and Northeastern Minnesota. RSI is enrolled to provide several of the HCBS waivered services. And so for people that we support with more severe disabilities, we offer corporate foster care and for adults and children. This service provides 24-hour support in a community residential setting. Director Merz described how the rate is set. I think the easiest way to think about it is how many hours a day they need and how many of those hours can be shared versus needing to be one-to-one, and that will determine the rate. Just a little bit more about the rate that I'd like you to make sure you understand is that there is a variance factor applied to the rate. So while it is a statewide framework, depending on the part of the state you're in, there is a variance just in the region we're in of 5.8% difference from one county to another. So that does affect our rates. And the other thing that can affect rates is that if we're serving a person with extraordinary needs or circumstances, we can ask the state for a rate exception, so the rate is set up outside of the rate framework. RSI also offers a variety of unit-based services. So these are not 24 hours a day services. These are based on an individual need. They're typically people who are living with their family or in their own home, and they're authorized based on the individual and are designed to address their particular needs and goals. We've heard this discussed about whether it's based on a person's disabilities or the things that are causing their need for support, or their abilities and what they want to do. And we try to combine that. So we offer a variety of supports, respite services for families and people who just need a break from each other, employment exploration services for people looking for work, housing access coordination to help people look for a new home, positive support services for a person needing help in managing disruptive or destructive behavior, individualized home supports to provide training on skills needed to live more independently. And again, these are services designed to help them decide where they live, where they want to work, giving them the tools they need to direct their own lives. And when it's done right with staff who have good training and can provide consistent support, the results of this can really be very dramatic. And I just want to give you one brief example. And it is a dramatic one, I'll give you that. But RSI was referred a woman who was struggling, had been in multiple settings due to very disruptive behavior. And she was referred to us. And the first thing we did was consider that those behaviors are really telling us that she wasn't liking how her services were designed. So we worked with her to design her own services. And for 18 months, we were providing one-to-one 24 hours a day. After 18 months, she was able to move into her own apartment and do a volunteer work in the community. Today, and for the past 4 years, this woman has been living in the community with 10 hours of service a week.
I'm going to have to interrupt you, Mr. Nelson. I apologize, but because these are televised, we have to end right on time. And so hopefully we can bring you back to the committee when we hear individual bills and hear all the great services you provide to people in Minnesota. So I want to thank members. This meeting is adjourned, and tomorrow we're going to hear about age-friendly program and the Vulnerable Adult Act. So I will see everyone tomorrow. Meeting adjourned. Thank you, everyone, and thank you to all the presenters.